Now we'll be doing the hip exam. You will start by having the patient walk. So if I can have you stand up and please walk back and forth across the room. You're evaluating the gait pattern, looking for any painful movements with the gait or any signs of weakness with the gait. You can go ahead and have a seat. You would have them walk back and forth as many times as you needed to get an adequate observation of their gait pattern. After that, we'll go ahead and have the, if I can have you lay down for me, please. Thank you. We'll have the patient lying down, and then you would expose the area. So by raising the gown, you're going to be doing kind of any inspection. Again, expose the area as you see fit for the hip. We're really going to be looking more towards the skin, expose it, again looking for any rashes in the area of the anterior superior iliac spine, any bruising or ecchymosis that you would note over the iliac crest, any swelling, obvious deformities. That's what you would want to assess at that point in time on the anterior part. You would also want to go ahead and have the patient bring your legs up, feet flat on there, and if you could have you lift your hips off the table, please, and then lower them back down, and then straighten out the leg. You're evaluating for any leg length discrepancies starting from the medial malleoli, tibial tubercle, and then finishing at the ASIS. Again, you're looking for any discrepancies in leg length, left versus right. You also want to assess, move on to the palpation area, palpating the iliac crest, feeling for any tenderness along that area, any swelling that you might notice. You want to feel behind the iliac crest, the iliac tubercle, again feeling for any tenderness in that area. You'll move forward to the anterior superior iliac spine, making sure that there is no tenderness. Palpate in that area, make sure there are no defects where the tendons insert into that area. And then you would want to, using the palm of your hand, move down till you can assess the pubic tubercles, assessing for any tenderness in that area, swelling, crepitus, or any deviation left versus the right. You'll also want to palpate from the tibial tubercle to the ASIS to feel for the inguinal ligament. You would want to do that bilaterally, feeling, making sure there are no hernias in that area or no tenderness. If you push deep to this area, the iliopsoas muscle comes through there, and you might notice some tenderness if there's a psoas bursa inflammation. And moving lateral to the hip, you could assess over the greater tuberosity and if there's any trochanteric bursal inflammation or tenderness in that area as well. While we have the patient laying supine, you can go ahead and assess for range of motion of the hip. Having the patient bring the knee forward, you're testing for hip flexion. While it's in the flexed position, you can test for external rotation and internal rotation of the hip. And always assess bilaterally, noting if there's any discrepancies in the range of motion. External and internal rotation of the hip. Evaluating also for pain or if there's any crepitus with the range of motion as well. If I could have you please lay on your stomach. Now we'll move to the posterior aspect of the hip. There are a few landmarks you want to evaluate here. Obviously, you're going to want to expose the area. Is it okay if I bring the waist, the line of the shorts down a little bit? You want to get to the level that exposes the PSIS and the sacroiliac joint. Again, you're looking for any swelling, any bruising, any abrasions, or any discrepancies in musculature through that area. Again, palpating along the iliac crest and tuberosity and getting down to the posterior superior iliac spine, palpating for any discrepancies there, and then the sacroiliac joint, feeling if there's any tenderness along that joint or if there's any swelling. While you have the patient in this position, you can assess for leg extension. So if I could please have you bring your leg up. I'm sorry, extend the leg all the way up. There you go. Testing for leg extension to see if there's any discrepancy from left and right. We will now go to the knee exam. I'm going to start with having you walk back and forth to evaluate your gait. So you will have the patient walk back and forth across the room, evaluating patient's gait, looking if there's any signs of pain or weakness. Go ahead and have a seat. Afterwards, you'll sit in front of the patient. You're comparing left versus right knee, looking for any obvious bruising, any ecchymosis, any swelling or effusions of the knee that are noticeable, any deformities of the knee, previous surgical scars, you would want to note that, or any abrasions. You can also assess the quadriceps musculature to assess if there's any discrepancy in muscle bulk between either the left or the right side. I'll go ahead and have you lay down for me. Patient lying in the supine position, you'll go ahead and start to palpate landmarks of the knee. Start anteriorly with the patella. If you could palpate over the medial portion, medial border and lateral border, what we call medial and lateral facets of the patella, assessing for any tenderness along there. Assessing down the pushing and palpating down the quadriceps tendon, including its insertion on the top of the patella, assessing for any defect in this area or any tenderness, as well as the patellar tendon, so starting from the inferior pole of the patella and palpating down to its insertion on the tibial tubercle, again assessing for fullness, presence, or defects of the tendon, as well as any tenderness along the tendon there. Go ahead and have the patient bend their knee to approximately 90 degrees with the foot flat on the table. You can now start to assess the medial joint line of the knee, assessing for any tenderness or swelling, and then to the lateral joint line of the knee, again trying to assess for any tenderness there. Go ahead and straighten your knee for us. There are a couple of tests that you can do to assess for knee effusion. One is to put pressure on the suprapatellar pouch and milk the fluid into the knee pouch. If you sweep across the knee here, you'll notice if there's any bulging of fluid on the medial aspect of the knee. If you see bulging on the medial aspect after sweeping on the lateral, that's a sign of fluid in the knee. If you were to push down on the kneecap and quickly releasing and seeing if the knee bounces up and down, that is a ballottement test. Again, that is looking for a knee effusion. You will assess range of motion of the knee, looking from extension, noting its angle, and then going to flexion and noting its angle there. You can perform the patellar grind test by putting pressure from an anterior to posterior direction on the patella and then moving it in a lateral and medial direction, assessing for any pain with that motion or crepitus with that motion, as that can be an indication of a patellofemoral problem. We'll move on to the McMurray's test, which will test for the medial and lateral meniscus. You will go ahead and bring the patient's knee into flexion. You'll evert the foot and then extend down, noticing if it produces any pain to the patient or if there is a palpable or audible pop that can indicate a meniscal injury. And then to assess the lateral meniscus, you would invert the foot and then extend out. So again, this is for lateral meniscus and this is for medial meniscus. This is the McMurray's test. You can go ahead and then assess for medial collateral ligament stability by, I'm going to have you move up, please. You're too tall. If we bring the leg off the side of the table and induce about 30 degrees of flexion, you place your cephalad hand on the outside of the patient's thigh, exerting a medial force with the cephalad hand and a lateral force at the hand at the ankle. And what we're doing is stressing the medial collateral ligament. You're assessing for a good solid endpoint, as well as assessing if that produces any pain. You can reposition yourself. So now your cephalad hand is on the inside of the thigh, your lower hand is on the outside of the ankle, and applying an outward pressure with the cephalad hand and inward pressure with the distal hand, you are now stressing the knee in a varus stress, assessing for lateral collateral ligament stability. There's the anterior drawer test, having the patient flex their knee to approximately 90 degrees with the foot flat on the table. You will take your fingers and put them behind the medial and lateral head of the gastrocnemius, and your thumbs will approximate each other near the tibial tubercle. You will pull from a posterior to anterior force, again feeling for any laxity within that movement, making sure there's a good endpoint. And then you will always want to compare bilaterally to see if there's a discrepancy. This is assessing for the integrity of the anterior cruciate ligament. The converse of that is the posterior cruciate ligament. With the patient in the same position and your hands in the same position, you're applying a posteriorly directed force, pushing back, and that is stressing the posterior cruciate ligament, or PCL. And again, you would want to assess left and right for any discrepancies. We will then move on to the Lachman's test, with the knee in approximately 15 to 20 degrees of flexion and slight external rotation. Your cephalad hand will grasp the distal femur for stability. Your caudal hand will grab the knee with thumb near the tibial tubercle, and you will pull in an anterior posterior direction, again feeling for a good solid endpoint and degree of movement, and that's assessing for the anterior cruciate ligament, and you would assess left versus right.